Thank you, sir, for introducing the subject. And thanks for so many people staying back. Last session, long day. I was glad that this was the last session because all the things that we spoke about today, I think I'm going to answer in this one presentation. I noticed a lot of experienced psychiatrists who spent years in the field talking about their pain in the difficulty in preventing and treating mental illness. We spoke about the difficulty in getting to the community and getting more people better. So I think I'm going to answer a lot of those questions, including the questions on mindfulness. I think the topic that was proposed was digital psychiatry in clinical practice. I just switched it a little bit to the inevitable future. It's not even the future, it's actually here, only that we as psychiatrists are not using it. A lot of people from other fields are actually using technology to take over what we're supposed to be doing. Now, when we start with the topic, I just try to say what digital technology is. Anything that we view on a scale, on a screen, is digital technology. Over the last 25 years, everything that we do, from buying diapers to diamonds, learning to cook biryani to build bombs, we learn from screens. All of us. These days, everything is learned from a screen. Nobody reads a book anymore. The advantage of it being digital, it is replicable infinitely for free. It does not cost anything in terms of resources to replicate an app or a document in a digital format. So now our role extends beyond just treating the people in front of us. It involves equipping the world to develop adaptive coping mechanisms so that we make self-reliant and healthy human beings going forward. Now, as psychiatrists, I think our job's quite difficult. My mom's a gynecologist. She spends an hour doing a surgery and charges 20 times what I do in an hour. I can see 10 patients a day. I'll make still a very small percentage of what she does. So we need something to help us out, hold our hand, and get more access to people. So today we're going to talk about how digital technology can help in these 5 aspects of our day-to-day care. So we're going to talk about access, how we can get more access to people, how it is going to help us diagnose and evaluate people better, how it is going to help us collaborate with people better, how it is revolutionizing treatment, and how it can improve maintenance and follow-up. So I am going to move from the present to the future in several parts of this presentation. In terms of access, like the chairperson said, when we started, the COVID pandemic kind of forced telepsychiatry onto us. So now if anybody from anywhere wants to talk to a psychiatrist, they can get an appointment and talk to them within the day. This wasn't the case a few years ago before the advent of COVID. But what I see that what is present today is nothing but a small glimpse of what is possible tomorrow. Telepsychiatry today is 2D. It's something like this. I wanted to talk about the telepsychiatry guidelines, but I'm going to skip it. But it's not really important at this moment. Let's look at this person. What do you think he's doing? If you can notice, he's wearing something on his head. There is a headset. And he's holding something in his hands, which are controllers. This person is experiencing another reality. So this is a virtual reality headset. This is actually the headset called the Oculus Quest 2. This costs only 30,000 rupees, but can immerse someone else in another headset. Just listen to me, build the idea of virtual reality. So the inside of the headset looks like this, wherein when you wear it, you're immersed into another world. And when you move your head, it is connected to a gyroscope. So the cameras move along and you're actually in another world. Let's say first I am visually in another world. Now this is a haptic glove, which means I can touch and feel temperature, pressure in the virtual world as well. Now I can touch and feel like the real world. These are biosensors which can make us, or actually measure our own heart rate, temperature, pulse rate, So, I've spoken about three things. There are sensors that are calculating very accurately what's happening in our body, everything. We are immersed in another world. We're able to touch, see, and feel. Now, include another concept. How many of you know this person? Can you please put your hands up? Kumanan sir, Sridhar sir, Ramakrishna sir, Tirliya. So this is my dad. This is Dr. Murugappan as an avatar. Because I made it and I'm not a professional, it's a little poor. But I'm sure if a professional made it, it'll be better. So an avatar is a digital representation of you in the virtual world. So like I was saying, we have a headset, we're feeling it. Just imagine how it would be if I was able to talk to my dad anytime I wanted. The next bit is I need to program that avatar with a personality and information. So that's where technology like GPT comes in. GPT essentially stands for Generative Pre-trained Transformer. A transformer is essentially software that converts letters into code. So now I am leaving it as an idea to be able to experience another world through a screen, through touch, and experience people whose personalities we can design quite accurately. I am sure everybody's mind is buzzing with ideas of how we can use this in psychiatry. It's not just exposure, it is everything. And now this person there, if my dad was replicable and constantly accessible to 100 people at a time, and all of us can put our feet up and practice mindfulness the whole day while my avatar takes care of all my patients. Now that's the future. But when I ask current AI in terms of what it thinks is going to happen, it doesn't think it's going to happen. It thinks that people are still going to play a role, but I think it's wrong. Because people are already developing technology. First resort is a virtual reality experience available for anybody to download and play if you have a virtual reality headset. It is a mindfulness and a CBT retreat wherein you wear your headset, you spend a few hours in a day, and this app is going to help you, guide you, learn certain things. There was a previous testing version of it which I tried out, which involved real people, but now it is a robot which will help you out. So now I spoke only about access, and I spoke about only virtual reality in access. And I think the future is very exciting. Now we're moving on to the next section of evaluation and diagnosis. I have to say this, but I am very disappointed that a lot of our theories on molecular mechanisms of causation of disease are not just enough for the person in front of us. Today morning, we listened to a presentation on schizoaffective disorder, which seemed, okay, we know something, but we don't know something. Then we listened to a presentation on antidepressants, which also felt like, hey, we know something, but we don't know something. Which is okay as a field as we are growing up, but it's just not enough for the patient in front of us. We need something more. We need to move beyond molecular psychiatry and move into other things that can actually help the person in front of us. Currently, when a patient comes to me, this is all I have. And frankly, this is not enough. All of us have people who keep coming back and don't get better. And when seniors spoke before me, I could feel their helplessness as well. When people said, okay, deal with the person in front of you, do the psychotherapy, prescribe medicines, that's not enough, we need more, and that is where digital technology is going to help us as well. In current states, this is a screenshot of a questionnaire on my website. Currently, we are still following a very subjective means of diagnosing and understanding issues. So this test is a DSM-5 made tool for personality dimensions. A person can take this online, they will answer questions like this, and they will come up with a result like this. There is a lot of subjectivity there. The same report, I look at it, I will interpret it differently, well, Dr. Sweta might interpret it very differently. But this is what we have in terms of digital technology today. Now let's say a future where medicine is precise, specific to that one person in front of you. It is live, active. So when a person is in front of us and we're talking to them, we are able to only collect information that we know to collect. Like someone said, the eyes cannot see what the brain does not know. But the human brain is limited. It cannot know everything. On a bad day, I can miss something myself, even if I knew it. Technology will not miss it. So in terms of how technology can help make a diagnosis in a few minutes, as we have a casual chat, I'm going to explore just a few studies, again not done by mental health professionals, done by technologists and laryngologists. So when a person is in front of me, there are a lot of changes happening. His facial expressions are changing, the speech tone is changing, there are gestures, body postures, the frequencies in the brain are changing, heart rate's changing, variability is changing. So a lot of this can be measured and can offer a lot of useful diagnostic personal information. So the first study I want to talk about is one wherein a group of researchers tried to diagnose mental illness just with an audio sample. So essentially, they picked up 363 people who were already part of another study in the university. They were known to have mental illness. Then they were asked to speak for 5 minutes about their children. In this 5-minute space, they kind of analyzed the audio in such a way that to a 75% accuracy, they were able to diagnose whether this person had depression or schizophrenia or bipolar disorder. Now, I see a pitfall in this because we barely know what depression, bipolar, or schizophrenia is. They are all very overlapping at the end of the day. So that is what is limiting these guys as well. So when you go to ChatGPT, I'm sure all of you have gone, we type in, hey, I am excited. When I say, hey, I am excited, it doesn't show whether I'm excited or not. So what these guys have done, they've taken the voice out. They've also tried to figure out whether the tone of the voice, the pace of the voice also means excitement. So a patient comes to me and says, hey, I'm suicidal. Might not really mean they're suicidal, but this will pick it up. Whether the tone is in accurate sync with it or not. So this is a summary of what they did, and on the right is the color coding is based on how much emotional depth the algorithm found when these people are reading those sentences. It even picked up some sort of sadness when this person said, So this is another study, similar, wherein they used sound audio analysis to pick up psychiatric disorders. But look at the range of disorders they tried to figure out. They tried to differentiate between OCD and anxiety just by speech. And the number of features that they could just figure out from speech, including frequency and jitter and shimmer and speech rate and articulation rate, it's just mind-blowing. And human brain cannot do this, but technology will help us do this. So in this study, they figured out 3 things. That they figured out there were weaker effects of pitch variability that were noted in schizophrenia. In bipolar disorder, there were longer pauses in speech. And in bulimia nervosa, there were features such as jitter, shimmer, frequency. So if they were listening to my voice, I don't know what they would diagnose for me. So we spoke about just sound. Just software listening to sound and diagnosing based on sound with very small samples. What would take us years, they do in 3 minutes, 5 minutes. Now this is another study where they used a study of facial expressions to figure out a way to diagnose mental illness quickly. This is not new. This theory has been around since the 1900s. There used to be something called physiognomy, where people's personalities were detected by how they looked. It was debunked as pseudoscience long back. This particular study looked at hemifacial asymmetry to figure out whether this person had a certain kind of mental illness. Again, this was not done by a psychiatry team or a psychology team or a mental health team. This was done by an AI team trying to figure out a way how to do this. So in the facial dynamics study, they used this process called coherence sequence kernel to figure out that there was some rigidity and some vigilance in faces, and in learning to discriminate between them, you were able to identify different diagnoses. So in the previous presentations, Veda ma'am was showing us some QEEG images. I have an interesting personal experience. I am quite a contrarian. I don't believe in things very quickly. The first time I heard of QEEG and brain mapping, I thought can't be true. It's too good to be true. You can't do this and figure out anything. But then there is Dr. S.P. Murugappan doing QEEG brain mapping in Chennai, and we attended his workshop and decided to send him patient M. So patient M is someone who came with obsessive features, specifically related to cleanliness and compulsive washing, quite severe, could not tolerate SSRIs, had severe anemia, and took her 6 months to come out and tell me that, hey, I had this really bad incident when I was a child. I want help, but I can't talk to you. I don't have the energy to do it. I don't want to take medicines. What can you do for me? I said, go to this doctor. He's not going to talk to you. He's going to put some wires on your brain. He's going to tell you what exactly happened. So this is part of the brain mapping image that comes out. So each of those numbers are frequencies of the individual EEG recordings as in the waves. Dr. S.P. Murugappan will look at this and quickly say, okay, this person is this, this and this. So whatever I told you about this person reflects in this particular number. For example, this temporal lobe wherein it says there is high beta percent and beta percent, that number of over 15% on beta percent essentially means there's been some sort of trauma. This is something I heard in the workshop, then sent this patient. This patient never told the doctor that she went through trauma, but he figured it out with this. The Swingle ratio of 63% essentially means this person's a little stubborn, which I knew because the patient told me, but Dr. Murugappan knew because he just did a brain mapping. This is even more beautiful. So focus on the last column of high beta, which is a dysfunctional EEG rhythm. Depending on which location you see the high beta, you can predict symptoms as well. So he said this person is going to have visual sensitivity, headaches, sensitivity to touch, rigidity, anxiety, and obsessive symptoms. I don't know if it was a Barnum effect or not, but I was sold. This is working, and this is such a quick and reliable method of diagnosing someone. Only thing is, this will not fit into our classificatory system, and we might think that this is wrong, but our classificatory system must be wrong. So we are still in the topic of diagnosing and evaluating, right? So it is already so exciting to see that so much is happening that can make our jobs so much more precise and easy. How many of you here have heard of this term digital phenotyping? I know one of our chairpersons has. Anybody else? One. So phenotypes, all of us know what phenotypes are. So a digital phenotype is essentially a model of me based on my interactions with a digital device. All the devices we use, my watch, my phone, have sensors, light sensors, accelerometers. They know what I'm saying, they know what I'm typing. They can create a certain image of who I am and can predict what I'm going through and what I may do. In terms of preventing things like self-harm or suicide, this can be quite helpful to start off as an experiment. This is already happening. Again, the work is not being done by psychiatrists. Now, I chose to put up this particular study of digital phenotyping in molecular psychiatry because this is a great link. There is this allostatic role of oxytocin, something that recently came up, that oxytocin is that one that is going to help your brain be flexible and deal with adversity. And this article was between a person who's working on digital phenotyping and the person who proposed this allostatic role of oxytocin, sitting down and talking, hey, how can we miss this opportunity? We should have done more work on it. And hopefully they're going to do more work on it. So that is a very mild glimpse into how much digital technology can help with diagnosis. Now we're coming back to the present a little bit, far away from the future. When I say future, I'm not talking decades, I'm talking few years, but back to the present. When a patient comes into my clinic, I don't prescribe medicines. I talk about medicine options. I don't diagnose people. I tell them this is what I'm thinking, why don't you read about it? We'll come up with some sort of thing that both of us understand. So right now, digital technology that is accessible through a screen, I'll come back to this study. A simple article. I have a blog, I have a website, I write articles on it, breaking down disorders into words that I understand, which I share with my patients. If they agree, that's what they have. Neither of us know if that is the truth, but that's what we work on. We also send in information about medicines. I don't want them to know all the nonsense that's on the internet. So I write my articles on what I think an antipsychotic is. So if, for example, in where I've written antipsychotics are used to treat depression and anxiety. So when I give someone aripiprazole who has depression, if they read this, they're going to be okay. If they're going to Google aripiprazole, they're going to go to schizophrenia and Dr. Kurtingen. The third kind of articles I write and share with my patients are how do you help someone who's suffering in your own family, has an eating disorder, schizophrenia or anxiety. There's very concise material. It will not take, so the reading time for this article is 3 minutes. Now going back to this first study. So in the UK, where a lot of effort goes into psychoeducation and effort goes into community mental health, apparently, they did this study where they designed this really elaborate psychoeducative and supportive system where people had access to professionals and compared it to a simple handout. At the end of the day, the handout won. There was no improvement in terms of all this elaborate work that was done. The handout won. So simple implementation of our own social media networks. If you have a blog, if you have a website, write it, your patients will engage with it a lot more. This is also something I wanted to add on. So when I prescribe, people have a lot of questions about drugs. They are a little scared of them. So all of us are familiar with this website, drugs.com. Drugs.com has a section where there are reviews for drugs, where people leave reviews for the drugs they've taken. For example, if I suggest quetiapine to someone and they're going to read about it, they're never going to get to this page where 131 people have said that quetiapine is something I've taken and this is what it did to me. So in terms of collaboration, giving my patient as much information as they need in terms of understanding what they're going through, the treatment options that we're taking. Again, digital technology makes it much, much easier for us to do it. It is not impossible without digital technology, but it's just more accessible. Now coming towards the last end of the section, the presentation. Now we've diagnosed people, digital technology has helped, I'm collaborating. Now I want to treat people digitally as well. I don't want to put a substance in them that causes harm to them. Now there is this whole field of digital therapeutics, which are essentially designing software programs that can help with behavioral and mental health disorders. They are supposed to be prescribable programs. They're already out there. There is an actual digital therapeutics alliance which adopts guidelines and ethical principles, which helps bring people who are developing apps together to figure out a consistent way of making software that helps. This is an example of the Substance Use Authority of the US of A with their framework to assist stakeholders in technology evaluation for recovery. So they have certain criteria that people who are developing apps will have to fulfill before they are going to be treated as a digital therapeutic. How many drug companies can you identify in this slide? So there is Sanofi, there is Roche, there is Pfizer, there is Boehringer. So these are part of the digital therapeutic alliance. Even the drug companies are moving over to make a quick buck. These are some of the apps in the digital therapeutics website. We will discuss two of them. So Reset is the world's first FDA approved digital therapeutic. It's not a standalone. It was designed for any kind of substance use, but the app that was released was for opioid use. It was developed based on community reinforcement principles, wherein we are not only making people stop use drugs, but we're getting them to engage with the community and deal with it differently. It has 62 modules, 30 of which are core modules and 32 are additional modules. There was around a 10 to 15% increase in retention rates and abstinence rates in people who use the Reset versus standard care. Now, this video might not play, but this is a simple video of a game that again is part of the Digital Therapeutic Alliance, an FDA approved game for ADHD. So according to the research they have done, 73% of people improved and 68% of people sustained that improvement. We are in the topic of treating people. So now we are talking about virtual reality again, not from access standpoint, from a therapeutic standpoint. This is actually a very famous picture when Oxford started working on virtual reality with psychosis, when they recognized that exposing people to this subway with a lot of people actually extinguished their threat response and reduced their psychotic symptoms without really any change in dose of medicines. It was path breaking at that point, but this is almost 15, 20 years old now. So I found a systematic review, which is surprising. I didn't know that there was so much work being done, but most of the work was being done for pain perception, anxiety and phobias, neurodevelopmental disorders, and some studies for other mental disorders as well. So virtual reality as a technology has a lot of scope, but for now we cannot depend on people to tailor make apps for our disorders. We will have to use virtual reality to help people in any way we can, being as innovative as possible with using current experiences. My experience with commercially available virtual reality apps are that they are more or less useless, will cost your client a lot of money, will waste your time, but is not really beneficial. Using simple games and experiences for exposure or to build any sort of skill you want for them helps. Coming back to neurofeedback in an intervention point of view, neurofeedback has been around for 40 years, which means connect people's heads to electrodes, use the electrodes to connect something on a screen, play a game and train a part of the brain. Sounds too good to be true. So this bit in the workshop that me and Sweta ma'am avoided, sir was quite optimistic about neurofeedback, but again, I'm not someone who believes in things very quickly. Before we go into whether neurofeedback works or not, neurofeedback does not cost a lot. Virtual reality does not cost a lot. A virtual reality headset, the latest one costs around 40,000 rupees. This headset, which is an EEG neurofeedback headset, costs the same, around 40,000 rupees. And patients can buy it, you can buy it, which adds another layer of intervention. So this one, which is called the Muse, has forehead sensors and the ears are also sensors. The Mind Lift is a software application for which the Muse can be used, for which another external EEG lead can be attached to train different parts of your brain. I know there is at least one hospital in Tamilnadu that uses Mind Lift. That is something I heard from a client. I have spoken a lot about therapeutics, and I also spoken about neurofeedback being around the longest in terms of digital therapeutic. Now, this is the problem with digital treatments. There is a systematic review on ADHD that says, hey, neurofeedback works, but less efficacious when compared to methylphenidate. And then on a very, very reputed website, an article pops up saying neurofeedback for ADHD, time to call it quits. Because the second article was way more advanced. They didn't use EEG for neurofeedback. It was actually a very complex and enviable actually design, because they used fMRI neurofeedback, which has much better spatial and temporal resolution. They recognized that it did not really make a difference. They kind of came to the conclusion that these people sitting still for 20 minutes might have worked better than the neurofeedback itself. Might have been, so this is where we're at. We don't know if it works. We don't know if it doesn't work. But it's there, and that gives us an option. So we've spoken about access. We spoke about diagnosis. We spoke about collaboration. We spoke about treatment. Now let's talk about monitoring. I'll come back to this. How many of you have heard of this or seen this? So this is a Government of India self-help mental health app, which is available to download for free. And it has self-help modules on sleeping, on communication, on social relationships, on mindfulness. This was announced around 2020. I think you might be more familiar with the e-Manas platform in Karnataka, where they're using it to record and as EHRs. This was part of that project and it's been launched. I didn't know it was launched, but while I was doing some research, I found it. So when I want to monitor someone, I want to make this process as easy for them as possible. I am only putting up apps that are free, so you can actually suggest these for your patients. They don't have to cost, they don't have to pay anything. So this is the mood tracker, which essentially does not only help in bipolar, helps in anyone who you have difficulty figuring out what is happening or figuring out what the triggers are. This is an app I made 3 years ago in a strain of some sort of excitement. It's still there, it has no support, but it's a very simple CBT trainer where people can make a record, share a record, learn about CBT, figure out what distortions are. In monitoring, the first two things that I showed you require patient input. They have to type something in, learn something. But we are all wearing biosensors all the time. I have this habit of asking people to send me their sleep record if they are complaining of sleep problems. It helps identify who has paradoxical insomnia and saves a ton of effort in trying out different medicines. I also ask people to send me their resting heart rate to see if what we're doing is working. So this is an email one of my patients sent me 2-3 days back. We started therapy around 3 or 4 months ago. It started with, hey, this seems like trichotillomania. But as we were exploring, there was a lot of trauma, a lot of things coming up. And then we started speaking about mindfulness, and we started speaking about your ability to step away from painful thoughts. And she's been practicing mindfulness for the last 3 months, again based on an app. If you can notice, her HRV is actually improved, which means she's healthier. Her resting heart rate is actually reduced. Her autonomic tone is reduced. She is healing, and this is something she can see and I can see. No molecules involved, no tablets involved. Now, towards the end of the session, I think I rushed through, but I hope it was at a pace that everybody found comfortable. This is an app I suggest for a lot of people. It's called Smiling Mind. Smiling Mind is an Australian initiative. It has a lot of mindfulness-based exercises and courses. It is gamified in a way that people can make streaks and find streaks. So that's useful. Here, it does not take 30 minutes to do a body scan. 3-minute body scans, 1-minute breathing exercises, anything goes. The last bit is my favorite toy since the last 2-3 years. So when I initially came across ChatGPT, I thought it was just going to be another dumb chat bot which will just irritate me and not really help me. But when you know how to communicate with it, which means prompt engineering or knowing how to prompt ChatGPT, it can become very useful. For me, it helps in communicating empathy much better than I can because its language seems to be better. So if I'm going to tell this, hey, I had a client today, she was going through a difficult time, I want to empathetically communicate that it's okay to have a difficult time, the words that ChatGPT will come out much better than mine. If I want to write a medical letter for someone and I don't want to get them into trouble, I'm going to ask ChatGPT what to do. It will give me something, but this cannot be trusted completely. We need to know a little bit of grammar because sometimes it's wrong in spellings in grammar. Another interesting thing I did was in our month-end session I think a month ago, sent out a questionnaire. It was a Google form. I just wanted to see what ChatGPT would make of it. I just copied the data randomly, put it in a text file, and put it in ChatGPT. Said, analyze the data, tell me what you found. It was startling. I couldn't have done it myself. It would take me 2-3 days to come up with the numbers and the inferences. But it could do it fairly quickly. So this is a tool that I think all of us should use. It is not 100% dependable. That's why we're the doctors. But it makes our life much, much easier. But as this gets better, they are also going to launch something called Make Your Own GPT, which means you can train your own GPT based on a document. If you go back to that slide where I showed you this really not so great video of my dad, if I had a detailed enough document about everything that my dad did, I could still interact with him today. So that's where I'm going to end this presentation. And like I said before, I think digital technology is going to answer every question for us. It is not without its pitfalls, it's not without its ethical questions, it's not going to come without challenge. But I think psychiatry, like any other field, needs this at this point for us to move forward. Thank you.
Thank you.